Okay, hi, I'm Judy Krasna. I'm the Executive Director of F.E.A.S.T, and I'd like to welcome you all to today's webinar. If you don't mind, take a minute right now, please, and just make sure that you're muted and that your camera's off, and please stay that way throughout the duration of the webinar. And if you have any questions throughout the webinar, you can just drop them in the chat box in Zoom, and Dr. Becker will answer them at the end of the webinar. And now it's my pleasure to introduce our speaker. Carolyn Becker, PhD, is a professor of psychology and licensed clinical psychologist who specializes in the treatment of eating disorders, PTSD, and anxiety-based disorders. She is board certified in behavioral and cognitive therapy. Dr. Becker is considered a leader in the delivery of peer-led body image programs. She and her Trinity undergraduate students pioneered the blended task shifting, train the trainers approach to scaling the body project intervention that has been used by over 200 universities in North America, as well as numerous nonprofit partner organizations around the globe. Dr. Becker is a fellow of the Academy for Eating Disorders, the Association for Behavioral and Cognitive Therapies, and the Association for Psychological Science. Dr. Becker, thanks so much for joining us today.
Thank you very much for having me. Okay, so I'm going to share my slides, my screen.
Just a quick reminder, please, cameras and microphones off, everyone, please.
Okay, can you all see the slides?
Yes.
Okay, excellent. Let me just slide this box up over here so that I'm, okay, great. So first I just want to start by, hold on, let me see. I don't seem to be able to change. Let me switch how I'm sharing. Try this one. All right, there we go. Now I can change the slides. We're all good. So I just want to start by thanking Judy for inviting me to give this talk. And thank all of you for attending, and thank F.E.A.S.T more broadly for being interested in this topic. Our topic today is eating disorders, biology, and body image, finding common ground without blame. So my assignment, as I understood it, and this was my assignment given to me by Judy, one of the experts by experience that I just have so much respect for, was what I think of as sort of on the one hand, on the other hand problem that we have to navigate. So if we think about the first hand, or we start with on the one hand, F.E.A.S.T views eating disorders as a brain disorder or as a brain-based disorder. And Laura Collins-Leister-Mensch, who is somebody else who I just have great respect for, said in 2012 that viewing eating disorders as a brain disorder is a compass that can help parents find the right orientation to assist their loved one. So this perspective is seen as something that is really facilitative of advancing care and helping carers find the right approach to assisting their loved ones in getting over their eating disorder. And we know that F.E.A.S.T also seeks to end the historic blaming of parents and caregivers for their loved ones' eating disorders, which has been a longstanding problem, one that I think that has gotten much better, but still occurs, which I think is heartbreaking. And yet this is something that we really need to get rid of. And this brain disorder or brain-based disorder approach is seen as helping sort of move away from this blaming. I view the brain disorder approach as a corrective reaction to the sociocultural model of eating disorders, which predominated for many decades and often did lead to blaming parents very inappropriately, and also often led to worsened care. And I think it's important when we're looking at this one hand side of our space that we have to navigate, that this biological viewpoint is very helpful to many carers. And then we have the other hand. And the other hand is that research indicates that body dissatisfaction is a robust risk factor for the development of eating disorders. And research also indicates that reducing body dissatisfaction can, and I'm going to put a very important caveat in here, in some cases, prevent some eating disorders. And that word some is really important. In addition, some carers and many people with eating disorders can clearly identify the role that sociocultural appearance pressures played in the development of their eating disorder. And I'm going to propose that we should not or ignore their lived experience any more than we should ignore the lived experience of carers and people with eating disorders who say that body dissatisfaction played no role in the development of their eating disorder. So as part of this proposal, I'm going to argue that all of these experiences are important in our field. And in addition, we need to be particularly open to hearing about the lived experiences of those in higher weight bodies who experience full-bred weight-based discrimination, often on a daily basis, and whose eating disorders have been grossly understudied, because many of them will identify weight stigma thus, and body dissatisfaction as a cardinal feature of their eating disorder. Now, these two hands, I think, lead to a lot of confusion and misunderstanding. And I've been really lucky to talk to a number of F.E.A.S.T leaders about this over the years. Early on, it was much more contentious. And then Laura and I had a series of breakfasts where we talked about where we disagreed and came to some really amicable space. Sometimes we agreed to disagree. Judy and I have also had discussions. And so I'm really excited to be here to hopefully unscramble some of this confusion and maybe bring us to a somewhat more organized space. That being said, I am not going to pretend that I'm going to do a perfect job or I am perfect in navigating this conundrum. My hope is that we will sort of reach a place where we can embrace the dialectic. I have some training in DBT, and I'm very inclined to sort of say, there is a dialectic here, and we can look at two things that may be seemingly opposed and actually come to embrace both of them. If we were to embrace the dialectic, we would recognize that eating disorders are brain disorders and that body dissatisfaction plays a role in etiology in some cases. However, I fully realize that what may happen is that a number of us just agree to disagree. Even so, I think having this discussion hopefully will be useful. All right, so we're going to start our journey. And at the start of this journey, I need to warn you that we're going to geek out a little bit here. So I'm going to ask you to bear with me while we engage in our geeky little journey here, because I'm afraid that when it comes to body dissatisfaction and its role in eating disorders, the devil is in the details. One last caveat that I want to add here is about where I'm coming from. This is where I come from in terms of understanding etiology, not just for eating disorders, but all forms of mental illness. My day job is I'm an undergraduate professor of psychology. I work at Trinity University. We only have undergraduates here. And every single semester I teach psychopathology, where I introduce students to really deep thinking about understanding mental illness. And this is where I'm coming from. Like all forms of mental illness, eating disorders are complex conditions with a complex etiology rooted in biological, for example, genetics, psychological, and cultural environmental factors. There is no single risk factor that accounts for the development of eating disorders or any form of mental illness so far. Eating disorders and all forms of mental illness result when a perfect storm of risk factors collectively clears some threshold. What this means is that complexity is at the heart of etiology, and we need to abandon the search for simple answers. We know that eating disorders are neither Mendelian genetic disorders nor sociocultural. For those of you not familiar with the term sort of Mendelian genetic disorders, that refers to genetic disorders that are influenced by one gene. So for instance, cystic fibrosis runs in my family. And if my parents had passed down 2 recessive mutations for cystic fibrosis, I actually carry one of those mutations, but my mother did not pass one down, I would have had cystic fibrosis. Cystic fibrosis is considered a Mendelian disorder like PKU, Huntington's disease, and a number of other disorders where we can look to a single gene. It is crystal clear at this point that neither eating disorders nor any other form of mental illness is going to look Mendelian. It's going to be many different genes all contributing small components. But we also know that eating disorders are not purely sociocultural disorders. It is clear there is a significant biological factor. And I think it's important to remember that if we insist that the word cause can only be used for necessary and sufficient etiological factors, then nothing can be said to cause an eating disorder. And what I mean by that is, again, using the cystic fibrosis example, it's very clear that genes cause cystic fibrosis. All I need are 2 recessive mutations and boom, I have cystic fibrosis. So genes cause cystic fibrosis. Genes can contribute to the development of eating disorders, just as sociocultural factors can contribute to the development of eating disorders. But we do not to date have a single factor that is both necessary and sufficient for the development of eating disorders. So whenever we think about what causes an eating disorder, we need to think about complexity and multiple factors at the same time. All right, so returning to our geek out here. I'm going to ask you, I hope that this will be fairly short. This is the only majorly geeky part, I think, of this talk. But it's important when we talk about risk factors to address the reality that there have been significant terminology problems. Indeed, historically, the term risk factor has been used so inconsistently that Helena Kramer and Stuart Agris and their colleagues in the early 2000s decided that they needed to develop a typology of risk factors. And understanding risk factor typology, I believe, is critical in making sense of the term body dissatisfaction is a risk factor for eating disorders. Because I'll talk to a lot of people about this and they'll come back and say something and I'll be like, they don't understand our risk factor typology. So I want to make sure that we're all on the same page here. This is, bear with me on the geek factor. Okay, so when we think about risk factor typology, there are different categories. And the first is a non-correlate. And this means something does not have any significant association with the onset of eating disorders. So we can dismiss that right now. The second is a correlate. And this is what many people think is the case with body dissatisfaction, that there's a statistically significant association between body dissatisfaction and onset of eating disorders. And that, in fact, is true. It is a correlate. And I'm going to re-show this again in a little bit with green and red to make it clear. We discover that something is a correlate using cross-sectional studies, epidemiological studies, case control studies, family or family studies. Now, something moves beyond a correlate to a risk factor when it has a significant predictive statistical and clinical association between the factor. In other words, it must have temporal precedence. What I mean by that is it must come before and predict the onset of the disorder in a longitudinal study. There also could be a fixed marker, and this is a risk factor that cannot be changed or changed spontaneously. For instance, we could say that maternal influenza is a fixed marker for the development of schizophrenia. It is predictive. It occurs before it shows up in longitudinal studies, but it's not something that we can mess with. Either you had it or you didn't have it. Variable risk factor. This is a risk factor that can be changed or can change spontaneously. And again, we're gonna detect this in longitudinal studies. Variable marker. Actually, I'm going to back up. Influenza was not a good example for schizophrenia. Typically, a better one that we use would be sex, the sex that you're born with. If there is a sex association, we can change gender, but we don't change sex. Variable marker. This is a variable risk factor, but purposeful manipulation does not change the onset. And what this means is that if we try to manipulate it in a randomized controlled trial that is, say, preventative or therapeutic, it doesn't change the disorder of interest. And the holy grail for risk factor researcher is a causal risk factor. And what this means is that it's a variable risk factor, and purposeful manipulation does, in fact, change the onset of eating disorders down the road. And in order to demonstrate this, we have to have a randomized clinical trial that is preventative or a therapeutic intervention study. Now, some other important considerations when we're thinking about risk factors is the issue of whether or not a risk factor is specific or non-specific. If a risk factor, even a causal risk factor, increases the risk for other disorders, then it is non-specific. For instance, childhood sexual abuse is a non-specific risk factor for the development of eating disorders. And we say it's non-specific because childhood sexual abuse increases the risk for most, if not all, forms of psychiatric disturbance. And many, if not most, or even all risk factors for eating disorders are likely non-specific. So at this point, I don't know of any risk factors that seem to just increase risk for eating disorders. Now, I'm going to take a quote from Tim Brewerton here because I just really love the way he said this. Non-specific does not mean non-important. So for instance, over here on the left hand of this slide, we see tobacco smoking, and we can see that that cigarette smoking increases risk for larynx cancer, esophageal cancer, myocardial infarction, systemic atherosclerosis, bladder cancer, oral cavity cancer, lung cancer, chronic bronchitis, emphysema, peptic ulcer, pancreatic cancer, and the list goes on. What that means is smoking, although it is the single most potent risk factor for the development of lung cancer, is a non-specific risk factor for lung cancer because it also increases your risk for other things. Lead is also an example of a non-specific risk factor. As you can see here in this graphic, it increased risk for brain and nerve damage. It is associated with, prospectively associated with decreased mental ability and learning difficulties, anemia. So it's associated with many, many things. Now, I think lead is a really interesting example because we can look at other things that also predict exposure to lead. So for instance, we could say that exposure to lead is a proximal risk factor for brain and nerve damage. But socioeconomic status is in fact a distal risk factor for brain and nerve damage that is mediated by the toxic effects of lead. Because if you have lower socioeconomic status, you are more likely to be exposed to lead. So we can also see here that adding more complexity to this is risk factors can layer on, and some can be more distal or more distant, as in the case of SES, and more proximal, as in the case of lead. Another example here is asbestos. Which increases risk for mesothelioma, lung cancer, larynx cancer, asbestosis, pleural disease, likely also ovarian cancer and stomach cancer, and a host of other problems. So again, going back to Tim Brewerton's point, non-specific does not mean non-important. And if you think I'm not done with the complexity, I'm afraid that we still have a little more complexity that we have to consider, because even causal risk factors may not be causal for every case or always cause. So let's use our smoking and lung cancer example here again. So not all cases of lung cancer are caused by smoking. Indeed, 10 to 15% of people who die from lung cancer never smoked. And only a portion of these cases are accounted for by secondhand smoke. I actually know someone from high school who developed a non-smoking case of lung cancer, and she's constantly trying to warn people, like, just because you didn't smoke from lung cancer, just because you didn't smoke doesn't mean you're not at risk for lung cancer. And adding more complexity, not everyone who smokes gets lung cancer. So for instance, if we look at rates of lung cancer in smokers, it's only 17% in males and 12% in females. Nonetheless, smoking is seen as the single biggest risk factor for lung cancer and accounts for 80 to 90% of deaths. So all of these things are true. And I think it adds a lot of a confusion about what we mean when we say something is a risk factor. Finally, research targeting one particular risk factor should not be interpreted as negating or denying the presence of other risk factors. For instance, research targeting high blood pressure to reduce cardiovascular disease does not negate the importance of a host of other risk factors. It also doesn't mean that everyone who gets cardiovascular disease has high blood pressure. All right, so hopefully you're all on board now and you're just like, oh, yikes, this is like really, really complicated. So let's look at how body dissatisfaction fits into the typology based on existing research. Body dissatisfaction is not a non-correlate. it is in fact a correlate, which is why that's in green. We do know that there is a statistically significant association between body dissatisfaction and the onset of eating disorders in cross-sectional and epidemiological studies. It also meets criteria as a risk factor because research has shown that body dissatisfaction, increased rates of body dissatisfaction, predicts the onset of eating disorders in longitudinal studies. So it doesn't just occur cross-sectionally, it doesn't just happen after the eating disorder onsets. It shows that at least in some cases, it is prospective and it predicts. It is not a fixed marker because body dissatisfaction is in fact something we can manipulate, though it's harder than heck to manipulate it. So it's a lot harder to manipulate than most people think. It is also, so it is considered a variable risk factor. This is a risk factor that can be changed or can change spontaneously. And we know this because we've demonstrated it in longitudinal studies. It is not a variable marker because research indicates that it is a causal risk factor. It is a risk factor that for which purposeful manipulation does change the onset of eating disorders. In other words, in randomized controlled trials, we have shown that if you actually are able to manipulate body dissatisfaction, which again, I want to caution is much, much harder than most people think, you can prevent some cases of eating disorders. So to give you one example of this kind of research, Stice and colleagues in 2008, and this research has replicated, randomized over 400 participants to a cognitive dissonance-based intervention that I wish they hadn't called healthy weight, but they did. An expressive writing condition and an assessment-only condition. And diagnosis was determined by the eating disorders examination. So these weren't questionnaire-based, these were actual interview-based. And what they found was that there was a 60% reduction of onset of eating disorders for the dissonance-based body image intervention at 3 years compared to the assessment-only control. And that's 6% versus 15. And that suggests for that every 100 people who went through the program, we could potentially have 9 fewer cases of eating disorders, which is actually really good news. What's important to note, though, is that this intervention did not touch 7% of the potential eating disorder, or 6% of the eating disorders. I apologize if I'm a little off today. As Judy knows, I did not get good sleep the last couple of nights because my dog has been sick. So it clearly didn't treat everybody, and that may be because those cases were not being influenced by body dissatisfaction, or the intervention didn't actually change body dissatisfaction in those people. I know for a fact this was a very clean outcome. It was, the analyses were only run because a reviewer asked for it, but as I've noted, not all cases were prevented, and they found something similar with the HWI intervention. Similarly, I think this is a really interesting study because this was a very high risk population. Martinsons and Jorensson Borgen reduced onset of eating disorders in an elite Norwegian high school athletic population. They had a year-long, very intensive intervention targeting body dissatisfaction, and they reduced onset at 1 year. And again, that was based on eating disorder examination assessment. So returning to some of those other important considerations that I raised, body dissatisfaction is a non-specific causal risk factor because body dissatisfaction increased risk for a host of other things, not just eating disorders. For instance, it may surprise you to know that body dissatisfaction is a very potent risk factor for depression. Indeed, actually at the Eating Disorder Research Society meeting, we had a non-eating disorders person give the keynote. And people were asking, how can the eating disorders field interact better with other fields? And she argued that body dissatisfaction was an important crossover because it is such a potent risk factor for the onset of depression. It also increases risk for suicidality, even when controlling for depression. I actually have a case right now, a young woman that I'm treating, and honestly, treating her eating disorder was not that hard. Treating her PTSD was a little more complicated. What's been brutal has been treating the body dissatisfaction, and it is the body dissatisfaction that has driven her 8-year high level of suicidality, and treating the eating disorder didn't tackle that. Importantly, and I've already made this point, but I really want to emphasize this, body dissatisfaction is not causal in all cases. You absolutely can develop an eating disorder without body dissatisfaction, even though research suggests it's a causal risk factor, because it is not a necessary and sufficient causal risk factor. Importantly, body dissatisfaction also does not always cause an eating disorder. You can have body dissatisfaction and not develop an eating disorder. So when you think about body dissatisfaction as a risk factor, I encourage you to think about it as something like smoking. It doesn't always cause it. It's not required in order to get the disorder, but it is one piece of the puzzle for some people. All right. So what I'd like to do now is for a moment assume that we actually agree. And I realize that I may not have convinced everybody, but we're just going to make this assumption for a moment. I'll give you the other assumption in a little bit. And let's assume that we agree that body dissatisfaction can serve as a causal risk factor for some eating disorders, even though it doesn't cause all eating disorders, and one can have body dissatisfaction without developing an eating disorder. I think the important question that raises really for the F.E.A.S.T community is, does that mean, and there's a typo there, some parents could prevent some eating disorders by preventing body dissatisfaction in their children, which could be interpreted as meaning some parents could be blamed for some eating disorders? And that's a question that I'm posing. And I want to give you a declarative no. It does not mean we can turn back the blaming clock and go back to blaming parents. And you may be wondering why, because if body dissatisfaction is something we can change, why can't that lead down the dangerous road to parent blaming? And I'm going to make the case that even the most dedicated parent can't fully stop the influence of the broader culture. I'm going to use a sort of funny example here from my sister. So my sister lives in Northern California. I have two nieces. And when my sister had her first child, she was very, very determined to try and keep her child sort of protected from princess culture. She had gender neutral toys. She had girl toys, boys toys, gender neutral toys, but she definitely tried to shield her child from princess culture. She also didn't have a problem with my niece eating candy, but my sister's something of a candy snob, and so she preferred for her to eat high quality chocolate and good candy that she was bringing from various trips from Switzerland and Belgium, as opposed to what she considers American junk candy. And I remember the day when she called me up and said, you know what? I do not know how my 5-year-old has been completely indoctrinated in princess culture when I have completely tried to shield her from it. But she came home today and all she wants to do is wear pink and be a princess. And she goes, and I also can't figure out where the hell she learned what the heck a Tootsie Roll is, because that's like the most awful form of candy. And I certainly didn't introduce her to it. I just use this as an example because I think that we have to be realistic that short of shielding your child like Rapunzel in a tower, you're going to have a very hard time keeping your child away from diet culture, which has its fingers in so many aspects of not just Western culture, but we've shared it with the world. And I'll talk to you a little bit about why I know that. You know, and so all of these features, whether it's the labeling of food, associating with work, with how you eat or what you eat, associating worth with how you look, the kind of weight stigma that occurs for people who are living in a higher weight body, if you just have the unfortunate genetics that you don't fit our current appearance standards and our current health standards. You're going to get it from your schools. You're going to get it from your physicians, because we know that the medical industry has a high degree of weight stigma. I mean, it's really impossible to avoid weight stigma. And so I'm going to argue that trying to stop weight stigma and diet culture is like trying to hold back a tidal wave. And I just don't believe a parent can do it, even with the best of intentions. And so I think we just have to be realistic about that. And one of the reasons I say this isn't just limited to Western culture, I realize that F.E.A.S.T is an international organization, is I've been lucky to be on the periphery of the expansion of the Body Project globally with the World Association of Girl Guides and Girl Scouts in the program of Free Being Me. And that's a truly international organization. And we've been really stunned at the full range of countries and the full range of girls globally, including girls in refugee camps, who say that addressing body image is relevant and important for them. And I'm going to share a little secret too about those of us in the body image field. And we don't usually talk about this, but every so often I'll end up in a conversation with one of my colleagues who dedicates their life to trying to improve body image and fight diet culture and battle weight stigma. And we will quietly admit that even we are not immune to the siren call that occurs in diet culture about, you know, changing things. Even though we know it's wrong, and even though we squash it very quickly, it's ubiquitous, it's everywhere, and it's impossible to be, I think, completely immune. And finally, I'm going to argue that even parents think they saved their child from body dissatisfaction undoubtedly benefited from some luck. Their child was temperamentally amenable to that kind of messaging. And even if you could stop the influence of diet culture, which I really don't think you can, remember that is just one of many different pathways to an eating disorder. So I don't believe that accepting that body dissatisfaction can play a role in some eating disorders, in fact, means that we have to return to the dark days, which I realize are still alive and well at times, of parent blaming. Now let's take the opposite approach. Let's assume you still don't think body dissatisfaction is a risk factor for some eating disorders. In other words, you may be in the body dissatisfaction is a risk factor for disordered eating, not an eating disorder camp. And I know there are a lot of people who are in this camp, and I can respect that. So here are some just considerations that I will throw out there potentially as seeds that you can sort of mull over. Number one is that the categorical model of mental illness is I'm not even going to say likely, it's wrong. More and more I go to conferences and everybody just sort of says it. The DSM and ICD are terrible. They're not accurate. They don't represent what is in fact occurring. I think the autism field is ahead of most of us in recognizing that the pathology of interest to the autism community exists on a spectrum, and it's not a linear spectrum. They like to look at it more like a circle. There have been increased conversations in the eating disorders field. I'm on a white paper that a number of us came together, a consensus white paper. And one of the interesting points that everybody could agree on, and I give Carrie McAdams credit for proposing this when we were having our discussions and trying to find common ground, was that the eating disorders field would be much better off if we moved to eating spectrum disorders and moved away from anorexia nervosa, bulimia nervosa, binge eating disorder, and just embraced the full continuum or forced circle, if we're going to follow the autism world, of eating pathology, and recognize that the lines demarcating the different forms of eating disorders and eating disorders from disordered eating really aren't clear, and the categorical model is deeply flawed. Some additional considerations. First is that diet culture is terrible for eating disorders recovery. So even if you are of the position that you don't believe that body dissatisfaction contributes to the development of eating disorders, I hope you can take this away from you. As Judy mentioned, I'm not just an eating disorders provider. I treat post-traumatic stress disorder. I have extensive training in the treatment of anxiety disorders. And I'll tell you one big difference between treating panic disorder, social phobia or social anxiety disorders generally, even post-traumatic stress disorder. OCD gets a little slippery here, but not a little more slippery during the pandemic, but not as much, is when I'm done treating someone for panic disorder, I don't feel like I have an entire culture encouraging my panic patient going back to the problematic behaviors that would lead to relapse. However, every person who recovers from an eating disorder faces enormous sociocultural pressure to engage in behaviors that could lead to relapse. And that is rooted in diet culture and in our sociocultural attitudes towards body appearance. In addition, diet culture makes many people miserable, particularly people whose weight is naturally higher. And these individuals, as I mentioned earlier, experience active pressure, active and ongoing discrimination on a daily basis. We know and are gradually acknowledging that their eating disorders have been phenomenally understudied, and that, you know, the active discrimination and body pressure that they face and the body dissatisfaction that they report are likely to be very, very linked. And so if you have a loved one who's in a higher weight body, I think it's really critical for you to realize that that recovery from them faces so many sociocultural barriers. And so being aware of the role that body dissatisfaction plays in overcoming an eating disorder is really critical. Diet culture also contributes to eating disorders in higher weight people and children being less recognized overall and in a timely fashion, because we think it's a good thing that fat people starve themselves. And I would say the last thing that I don't have on the slide here is that even if body dissatisfaction didn't play a significant role in the development of your child's eating disorder, diet culture and the pressure to have an impossible body may still encourage your child or your loved one to behave in ways that are not amenable for full recovery from an eating disorder. And so I'm going to argue that fighting all of this is good for us. Even if you don't agree, it contributes to the development of an eating disorder. Lastly, if you have a temperamentally vulnerable child, you probably want less body hatred and toxic food pressure applied to them, because eating disorder isn't the only form of psychopathology that could result. So it might be that it doesn't lead to an eating disorder in your child, that some other pathway led to an eating disorder, but it could still lead to depression. It could still lead to suicidality. It could still lead to other problems. And so when I look at the idea of tackling body dissatisfaction in the eating disorders world, to me, this is no different than parents with kids who had weakened immune systems wanting all of us to pull together to make the world more COVID safe. They weren't to blame for their children's immune system being weak. And yet there's a limit to how much they can protect their child from infections without locking them in a bubble, unless we collectively all make the world safer. And so to me, we want to tackle body dissatisfaction because we want to make the world safer for those people who are susceptible, because it makes so many other people miserable, and because people in higher weight bodies are really, really suffering. But that doesn't mean that it causes all eating disorders. It doesn't mean that people can develop an eating disorder for other reasons. It doesn't mean biology doesn't play a role. And it doesn't mean we should start blaming parents again. So in summary, I've gotten through this a little quicker, so we'll have plenty of time for questions. Hopefully I've been controversial enough or stimulated enough thoughts that will have something to do. Eating disorders can be both, in my perspective, biological brain disorders and disorders for which body dissatisfaction is sometimes an etiologic factor. Accepting the role of body dissatisfaction means accepting that our toxic food and body-focused culture can sometimes play a role in the development of psychopathology broadly, but it does not mean accepting that parents are to blame for their child's eating disorder. We can also fight back against powerful cultural forces that impede recovery in many people with eating disorders. This is actually a reason that Christina Safran was interested in looking at To the Body Project to sort of help people with recovery. And I've actually had a lot of students who had recovered behaviorally from the eating disorder, but they would say still felt the siren call to return to their eating disorder behaviors. But going through the Body Project, as one of my students said, was this, basically she goes, the Body Project was the stake that finally, went through the heart of the vampire and fully chopped off its head. And she said it wasn't as restless anymore, and she was able to sort of move on and be more fully recovered. And then I think we have to be really recognize that the body image forces that contribute to body dissatisfaction have really been part of global weight stigma towards people in higher weight bodies, and have played a role in the eating disorder stereotype, and had led to slower identifications of eating disorders in people in higher weight. We know that weight stigma leads to worse people whose bodies are higher weight. We know that weight stigma leads to medical providers not coming on board with eating disorder recovery plans for people in higher weight. And all of these things are linked together. All right. So with that, I know I got done a little bit early, but again, hopefully we will have some interesting questions. And again, I want to thank Judy for inviting me to give this talk and being open to, tackling conundrum and the not easy questions. I'm very grateful for that.
Thank you very much. This was really interesting. I personally love the non-easy questions. And I run toward them as opposed to running away from them. So I appreciate your willingness to do this with me. So the first question that we had, and so far the only one, so everyone please give in your questions. Can you explain a little bit about the Body Project, because some people aren't familiar with what
Sure.
it is?
Yeah. So the Body Project is a body image intervention. It was originally developed by Eric Stice as a eating disorders prevention intervention. I actually have long argued against marketing it as an eating disorders prevention intervention and have largely won that argument, which I'm really delighted to say, because body dissatisfaction is a non-specific risk factor. And more importantly, it's not like anybody walks through life thinking, oh, I think I'm going to develop an eating disorder in 6 months, so I should go get like eating disorders prevention. However, people are acutely aware that they're unhappy with their bodies. So the Body Project is a cognitive dissonance-based intervention. And what that basically, so cognitive dissonance is the uncomfortable psychological state that occurs when your actions and your beliefs are misaligned. It was identified decades and decades ago by Leon Festinger and is a key factor used in social psychology and the study of race. And so in the Body Project, what we do is we have people identify what is the appearance standard for their cohort. This is one of the reasons it has been successfully used globally. So the appearance ideal in a group of white high school girls in the middle of the South in the United States, who are all, as I said, all white, might look very, very different than this standard that we might get in a group of Latinas here down in Texas. And then what participants do is they speak and act against that appearance standard. So they discuss, we all know why it would be beneficial to look like the appearance standard, but they argue against the appearance standard. They say the costs of pursuing the appearance standard. What are the financial costs of pursuing this standard? What are the scholastic costs of pursuing the standard? What are the work costs? What are the interpersonal costs? What are the time costs? We do role plays where people engage in negative body talk and they argue back against it. There's a mirror assignment where they stand in front of a mirror and identify things they like about themselves, both physically and in terms of like self attributes, like they like their sense of humor. Most girls and women use the mirror as a tool of critique, not a tool of affirmation. There's a letter to a younger girl where they try and explain why you shouldn't pursue appearance standards. So it is the body image intervention with the greatest volume of research supporting it. It's been studied globally. As I said, we've partnered with the World Association of Girl Guides and Girl Scouts, and through them, it's been deployed to over 2 million girls, and they think the effects have reached 3.5 million girls. And as I said, surprisingly, it's ended up in refugee camps through that project. We've used it in universities, high schools, and it's a great program. It's not a perfect program. It's not going to prevent. It's mostly, this program is, honestly, the question is mainly for young people. It's mostly been tested in high school and in college. There's been some research trying to push it down to middle school. In adults, it gets a little more complicated because we also have aging issues that we have to address. Because even adults who have sort of come to better terms with certain appearance standards often struggle with the aging ones, and there's a little research there.
Okay, so I have a kind of a double question.
Okay.
So someone asked if you have any tips or ideas on how we can all learn to love our bodies more, imperfections included. And I want to add on to that. And I want to say, you know, as a parent, if we see that our children, not the eating disorder ones necessarily, but our other children experience body dissatisfaction, and we're concerned because we know that it is a risk factor. What can we do as parents to try to help, you know, mitigate, offset, you know, negate this body dissatisfaction?
So the first thing I'll say is I wish I had a magic answer. If I had a magic answer, like I would be like the richest person in the world, because I don't have a magic answer. It is a really, really tough thing. So one thing you can do is you can actually steal some ideas from the Body Project, and you can have conversations about the cost of pursuing appearance standards. So that's one of the things is, you know, really saying like, you know, what are the costs of pursuing this, reminding them that they're valuable themselves. Now, one book that I actually, I'm still experimenting with, so I'm going to be really, really honest about this. But I mentioned that I have that really, really tough case. And so here I am, like a global body image leader, and I have this patient. I'm just going to like totally admit, like I got eating disorder treated, like the eating was much more normal, and we got the PTSD under control. And I'm like, and my patient is probably going to still kill themselves because they hate their body so much. And this new book came out. This one is particularly when you're working with your kids in higher weight bodies. So this was a book published very recently. Let me see if I have the authors for you. By Hilary Canarvie and Dana Sturtevant. It's called Reclaiming Body Trust. And I'm only 96 pages of the way in it with my patient. It is particularly relevant for people who are in higher weight bodies, but they are also writing to people who are struggling with eating disorders. And I will tell you that this book has made progress where I previously hadn't made any progress with any other toolkit in my repertoire. I actually learned about it from Shivise Turner on Facebook. Sometimes social media is a tool for good, not often, but occasionally. And she said this was the book she wished had been around when she first started in psychotherapy. And I've actually just been reading it with my client. Like we literally will, and if she doesn't do her homework, we read it in sessions and we process it and talk about it. And so it's called Reclaiming Body Trust. And I have found this enormously helpful with somebody who was completely like non-responsive to all the evidence-based approaches. I think looking for ways to have your child interact with their body in helpful ways, like in like, you know, in finding what they like to do with it. And it doesn't need to mean to be exercise. You know, it could be, you know, crafts, or, you know, really talking about what you appreciate. And I apologize for that. I see the term about talking about suicide might be triggering for this community. So I apologize for that. I think, you know, having your child, you know, sort of look at their body and find things that your child enjoys doing with their body, and trying to move it away from weight and shape, and trying to move it away from body image standards. I think also standing up to physicians, pushing back on schools, trying to identify where they're getting the messaging from. Are they facing bullying at school, and trying to support them through that. But again, you know, as I sort of said in my talk, I think it's very, very difficult. And I don't want you as parents set up feeling like you are expected to be able to turn this back. You can help your child as much as possible, but it is very difficult to do. I know as parents who have worked with eating disorders, you understand difficult. Like you wouldn't be in F.E.A.S.T if you didn't understand difficult.
I mean, I think it's ironic that you're talking about pushing back against physicians. And, you know, we're talking about the new clinical guidelines of the American Academy for Pediatricians, where, you know, they're recommending, you know, medication for 12-year-olds and surgery for 13-year-olds. And, you know, how is that going to impact a child's body image? So I just wanted to throw that out there.
We are all deeply, deeply horrified at that recent recommendation. And I've actually been doing more work recently because I discovered that we do bariatric surgery in people with food insecurity who can't afford the post-treatment plans, because here in the United States, Medicaid will pay for it. So it's a cash cow, which means we're going to do that to adolescents too. And it's just really, really awful.
So an interesting question was asking about, you know, it's kind of a trend, I guess, to have oversized, you know, not oversized, I'm sorry, to have, you know, higher weight models, like in fashion shows. You know, at F.E.A.S.T, we kind of, you know, we're told about a project actually in Pakistan, where they're having a fashion show with higher weight models, you know, just to model different, you know, body diversity and different sizes. So is there any data of the perception of adolescents or adults about these higher weight models? Does it impact, you know, a person's body image? You know, if you see a higher weight model, does that change your thinking about, you know, that you have to be thin in order to be beautiful? Like, does that have any impact?
I'm not aware currently of any data. What I would speculate is that seeing it on a one-time basis isn't going to do much of anything. It's really more about trying to broadly change things for everybody. So trying to be honest that bodies come in all different sizes, and providing space for everybody to be seen. Let me take that back. I actually do know of some people who have said to me that even seeing somebody once in a higher weight body, say in a movie, where they weren't the sidekick, or they weren't the comedic relief, or they were treated like as a real person, mattered. And certainly I know from talking to some parents, some colleagues of mine who are Black, and the excitement that their girls had at seeing I know it was controversial, but the new Little Mermaid being Black, that representation does matter. And so I think it can matter, but I think the dosing also matters, and that it can't be like a token thing. We've got to like shift it like really, really broadly. An important thing is that I just learned this, is that even when we move into like clothing and more clothing options for people in bigger bodies, if your body is bigger than a 3X in US sizing, and I know sizes are very different globally, the options shrink tremendously. And yet there are lots and lots of people out there that are bigger than 3X. And just all the different messages that we send people that say, you are not acceptable as you are, and that your body needs to be modified in order to be acceptable. That, you know, none of it is helpful to living like a full and authentic life. Which is why I think it sets up, you know, multiple forms of psychopathology, not just eating disorders, and sets up multiple risk factors in terms of health as well. I mean, it sets up risk for malnutrition, even if you don't develop an eating disorder. It sets up, of all things, it sets up risk for lead exposure. If you have darker skin and you are somebody who lives in a culture that still uses lead-based skin lightening creams, it sets you up for lead exposure. So, I mean, it's just problematic in so many different ways.
It must be a frustrating space to work in for you, because you know the risk factors, you understand, you know, the influence of body dissatisfaction. But as you spoke about, we have this culture which basically praises thinness and equates thinness with health and forces people to be thin. So, you know, you were talking about it in terms of relapse, right. You know, but how you have to be so careful. But, you know, it must be frustrating that you know how negative the impact is, and yet you're still seeing it all around you. And I totally agree with you that it's kind of our job as a community, our job as a society to change the cultural norms, but that obviously is very slow going. So, you know, I think we can each do our part to whatever degree we can, but it's still very frustrating for me from the parent perspective that, you know, you have, you know, it's so much of what you spoke about was really on one hand, on the other hand, and how to kind of make everything work together. So I really did appreciate that. Last chance. Anybody have any more questions? Okay, I guess you were very clear. There's no more questions. I guess you were very clear. Well, this was really enlightening for me personally. You know, it really is a topic that, you know, it speaks to me because, you know, I loved that slide you had with kind of like the person's brain and like the ball of yarn all messed up. That's my brain, honestly. When it comes to topics like these, that's my brain. I have a really hard time wrapping my head around the whole, on the one hand, on the other hand, and reconciling the two so that we do believe, you know, in the brain and the biology and the genetics. And we also acknowledge the fact that there is this body dissatisfaction, body image, you know, piece to it. So I really think that for me, at least, you really kind of, you know, made that ball of yarn, you know, not all squished up in there. And it's a lot clearer to me. And I really hope that for all of you who joined us you also have clarity.
I saw one question where somebody said, how can you get your loved one the body project?
Yes.
That really depends on where you are and what age you're in. So it's more available in some countries than other. There are always materials available, and there are people who are willing to train. For instance, I'm just actually started collaborating with somebody in Princess Nora University. So if you're in the United States and she's 16, you can, so one possibility, so we were partnering with the National Eating Disorders Association, but their big mix-up or change of leadership and everything else, we're not actively partnering with them. So it's scattershot across the United States. You can reach out to me about where you're located, and I can reach out to F.E.A.S.T or some other people and see if it's locally available. That's on the upper end of the Free Being Me version, but you can also always reach out to the Girl Guides and Girl Scouts, because Free Being Me is widely available, and is something I know some schools have picked up and used the Free Being Me version. Are the strategies and activities. So if you want to see the activities, there's a couple ways. The website changed recently. Again, you can email me. Eric just changed the website where you can get the free materials. You can also just go to Amazon and buy the Body Project. So it is published by Oxford University Press, and the core activities are all in it. So if you just want to hop on Amazon and buy the book, F.E.A.S.T is the first author. But you can also, yeah, I can send Judy the resources and then she can send them around. That would probably be much more efficient than you all emailing me. So that's a really good suggestion. I will email Judy the various websites where you can get the information. Let me make a note of that right now to myself. Email Judy.
Thank you. Okay. Again, thank you everyone so much. If you like this webinar and you'd like to see us be able to continue offering free services, if you have an opportunity and the means, please go and give a small donation on our website. Every little bit really helps us. And we actually have a very busy month coming up in February because we have our Feast of Knowledge conference. It's February 26th. It's a Sunday. It's from 10 a.m. to 4 p.m. East Coast time, or if you're in the UK, it's 3 p.m. to 9 p.m. And it is a 6-hour jam-packed conference full of really riveting, fascinating, and interesting sessions that are helpful for parents and caregivers. It's totally geared toward parents and caregivers. And it's still, there's time to register. And also, if you can't afford it, $60 for an individual, $100 for a family. If you can't afford it, you don't have to worry about it. We offer scholarships to anyone in need. So everyone is welcome. Everyone can attend. Just be in touch with us if you need help with a scholarship. And otherwise, you can just go to, student discounts, no, unless you're a student and a parent. I'm sorry, we can only really help parents and caregivers. I wish we could help students, but if you happen to be a student and a parent or a caregiver, absolutely. And I also wanted to let you know that we actually have 2 webinars coming up in March. I didn't want to make it too busy, so we're not advertising them right here. But one of them is about Ramadan, and the other one is about fat phobia and how it affects eating disorders. So you can go to our website, you can check out our upcoming webinars. We have a lot of programming coming up. Please register for everything. And thank you again so much for joining us. And thank you again, Carolyn, for a wonderful presentation.
Thank you. Thank you for having me.